We have the slides, yes. So I invite Dr. Shaival Majumdar, Dr. Nilay Patel, Dr. Alpesh Patel. So we have two cardiothoracic surgeons here, and Dr. Mridul Sharma and Dr. VC Chauhan as two chairpersons who are cardiologists. Dr. Nilay Patel is a cardiologist, and Dr. Ketav Lakhia is a cardiothoracic surgeon. So we have a pretty balanced two surgeons as moderator and one cardiologist as a moderator, and two cardiologists as chairperson and one cardiologist as cardiothoracic surgeon as a chairperson. I would invite them, the chairpersons, to introduce speakers for the day. Dr. Priyank Bhatt and Dr. Mamas, my friend Mamas from UK. It's wonderful to see you, Mamas. It's always a pleasure having him. He's the most published guy. People used to tell me that, Kamal, how do you get these number of papers? And then I saw Mamas's profile. Last year he published 100, and he's 5,000 plus publication, and I have even yet to cross one zero taken out of it. I'm not even 500. So that's Mamas for you. I mean, of course we'll have official introduction. Over to chair. Dr. VC Chauhan, you need to unmute.
So can you hear me?
Yes, sir.
But I think you have to, Kamal, you have to read, because in my computer there is some problem. I can read only one line of the chairperson, the speaker. So by the time I fix
Dr. Priyank Bhatt,
let Priyank Bhatt or someone.
Dr. Ketav or somebody else from the chair. Please introduce both the speakers and the case, and then we move to debate. Ketav, please unmute. You are
now I can see it if it's required. So Kamal, I can introduce Dr. Priyank Bhatt.
Yeah, please go ahead. Please go ahead.
Yeah. So basically, I have never met Dr. Priyank Bhatt. It's a great opportunity to meet him today because of Kamal Sharma. So you made a lot of dreams come true. Basically, he's a senior cardiothoracic surgeon at Sal Hospital, and everyone knows how great Sal Hospital is. He's expert not only in routine cardiac bypass surgeries or revascularization, but also in MICA surgery, which is probably one of the essential things that all cardiac surgeons should know. If cardiologist is there, he should know rota. Same way cardiac surgeon must know the MICA, so that he's one of them. And he's also expert in doing mitral as well as aortic valve surgeries. And I think, Kamal, this is rare debate where cardiologists and cardiac surgeons are going to talk against each other. In majority debate we've seen, it's cardiologist versus cardiologist. And the second one is Dr. Mamas, who is, as Kamal very rightly said, is very famous, internationally known cardiologist from UK. He's basically FRCS for UK and MRCP from London. He has multiple current appointments. I'm not going to detail because his lecture will itself say what he is. But he is having a lot of international and national positions and responsibility, like actively participating in European Society of Cardiology, European Association of PCI, heart research of UK medical review panel, etc. So without taking much time, I'll ask both of them to go one by one for the debate. First is Dr. Priyank Bhatt. And I think, should I read the history or he will read the history actually? So Priyank, it's over to you to start actually.
Yes. Am I audible?
Yeah.
Please share your screen.
Yeah, I'm sharing. Can you see it?
Yes. Please make it slideshow.
Yeah. So at the outset, I have to thank Dr. Kamal Bhai. Thank you very much for having here. As Dr. Chauhan rightly said, it's like a dream come true. I have to also thank all his team. Prashant is here, Jignesh, Kalpesh, everybody. Thank you very much for having me. And I'll start off by disclaiming that I am a surgeon. I am like a rabbit in front of all of you lions. So please look at me in that sense. And as the history said, what are we supposed to do for a critical left main in a young patient? Usually there are three options, as we all know. CABG bypass surgery, you take Lima and put it on the LAD. or you can do a PCI. You just put a stent in the left main, 1 or 2 stents, double kissing, how. And third is medical therapy. We are not going to go into it because it's proven that it has worse outcomes in managing the critical left main, and alone left main is totally insufficient. Surgery has been the gold standard for left main over the years. We all grew up learning that left main is like the holy grail. Once the left main was diagnosed, it was immediately sent. And when I was, learning cardiac surgery, left main was an emergency. It still is. And we used to treat it like that. We used to get a left main and we used to operate at 1 o'clock, 2 o'clock in the night. Because there is a large area of myocardium which is at risk, it necessitates surgery on the emergency basis. And it has been treated as such till now. Some of the recent trials and controversies about them have tried to change this path of care a little bit. This is 2018 ACC guidelines. Left main was class 1 indication for CABG in almost all the scenarios except proximal LAD disease. These are the newer 2021 guidelines. I have just kept the screenshot of the significant left main part. That significant left main stenosis still remains in all the scenarios, whether it is anatomically complex or not complex. It remains grade 1, class 1 indication, with or without the discussion with the heart team. PCI is in non-complex diseases is grade class 2A indication. This is 2021 guidelines, which it came into 2A from 1. Historically speaking, these are the trials that have happened over last few years. It started with Le Mans in Poland, and now it's the Excel, which is the multicentric US and Europe trial, which has generated the controversy. If we can focus on the last 3, Syntax, Excel, and Noble, diabetes prevalence or the LVEF were quite similar in both the PCI and CABG subsets. Average Syntax score was also quite similar in all 3. Composite outcomes in all the cases, in all the trials, have been either inferior or non-inferior. It has never been superior except for the stroke rates in the Syntax trial at the end of 5 years for PCI. In all other scenarios, it has remained inferior or non-inferior. I would like to point out that in Syntax, we do not know how many LEMAs were used and how many surgeries were off pump. In India, especially, when you see that most of the surgeries are going to be off pump, almost all surgeries are going to use LEMA, the stroke rates are going to be less, certainly. If we start off with Noble trial, which compared stenting to CABG with regards to death, MI, and repeat revascularization, it found that stenting fared worse than by CABG for this combination of outcomes. The difference was mainly due to higher rate of MIs and repeat revascularization. There was no difference in stroke or death in the 2 groups. These are the results of Excel trials also at the end of 5 years, which say which had the similar kind of outcomes. The MI generated the controversy, which we'll see in a minute. Noble and Excel were quite similar in their design and primary endpoints, but differed in the sense that repeat revascularization was not the primary endpoint in Excel, and peri-procedural MI, which was excluded in Noble. This became significant because Noble and Excel both had higher rate of repeat revascularization and non-procedural MIs in PCI groups. And this drove the major adverse effect for PCI. In Excel, the primary endpoint was death, stroke, or MI, and it was similar in both PCI and CABG. The higher rate of repeat revascularization was in PCI, which was considered a secondary endpoint. While the rate of MI in XL was similar in PCI and CABG at 3 years, this was primarily driven by the higher rates of peri-procedural MIs, and the definition and the criteria to define peri-procedural were changed, which we will see. So non-procedural MIs, which happened later on, which were used in Noble, tended to be higher in PCI for PCI in XL at the end of 3 and 5 years. So this generated the controversy. This is the editorial article in European Cardiac Review Journal of 30th March last year, which showed that XL trial had many strengths, including its recruitment and successful follow-up of a large number of patients. The interpretation of his finding has generated controversy. The lead surgical investigator, Dr. David Taggart, withdrew his name from its final publication. It reached to that extent. Moreover, in December 19, European Association of Cardiothoracic Surgery Council withdrew its support for the treatment recommendation on left main coronary artery disease, which were based on the XL trial findings. We, as surgeons, had two problems. The committee said that the overall results at the end of 5 years in XL for PCI and CABG were neutral. They were non-inferior. The authors reported that patients with left main coronary artery disease and low syntax score, the primary endpoint death, stroke or MI at the end of 5 years was 22% in PCI and 19% in CABG, and concluded that there were no significant differences. All-cause mortality at the also was considered quite similar. The mortality actually at the end of 5 years was 38% higher in PCI arm compared to the CABG arm. So we subjected the XL data to Bayesian methods, which give probability estimates of clinical interest and allow the consideration for pre-existing evidence and how it can influence the test results. And what it showed, reanalysis, is that mean difference regarding incidence of primary composite outcome was 3% lower in CABG group, whereas mortality was 1% lower in CABG compared to PCI at 5 years. In multiple systemic reviews have generated the same results. So this suggested that long-term results with the use of PCI in left main are inferior to CABG. And second bone of contention was that different definitions of MI were used in the XL trial. In the XL protocol itself, the universal definition of MI from the European Society of Cardiology was used, and it was supposed to be used. However, XL investigators used this Society of Cardiovascular Angiography and Interventions definition later on. This was problematic as universal definition was pre-specified secondary endpoint in the original protocol. So David Taggart, one of the principal investigators, stated that the change in MI definition related to the fact that main protocol, which was saying that we would be using universal definition, was not adhered to. In the appendix of the protocol, there is a new biochemical definition of MI that had never been employed before. So why this change later on? If the original plan was to use creatinine kinase definition along with this, troponin assessment was very optional, and it was not used in majority of patients according to the authors. A large discrepancy has become apparent in number of CABG-related procedural MIs when data using two different definitions are compared. I will just skip to a slide. When you are using different definitions, if you are using the second or third universal definition, which was supposed to be in the protocol, the MI in the PCI was came out to be 18% or 3%. But when you use the newer definition, the biochemical definition, the peri-procedural MI became 18% in the CABG. It is quite natural, as if you handle the heart, the CPK is going to rise, which may not be significant or which may not be translated as MI. So, a lot of societies, lot of surgeons had a problem with this interpretation of data. Indian Journal of Thoracic Surgery and Thoracic and Cardiovascular Surgery last year came out with the addendum and with an entire journal edition when it said that medicine has been turned on its head. Again, they will to quote.
Yeah, sorry to disturb, but concentrate more on the case that we are going to discuss in your case.
Yeah, so I will just
otherwise time will run out. Yeah.
So this is the controversy. So if you look at the what you call the data or the original recommendations since 2018, or even the lower, I mean, later on recommendations, anatomically complex left main, which is the case, it should undergo bypass surgery. If possible, which is possible in this case, as patient is a young patient, and it's quite possible. In patients of low or intermediate anatomical complexity, role of heart team is there, and surgeons, cardiac surgeons, cardiologists, and the patients can sit together and discuss and decide. I would just end my presentation with a quote from a book of Talmud, that do not unto others what you would not have done to you. That is the whole law, and rests are just commentaries upon it. Thank you very much.
Yeah, thank you very much. Now I would invite Dr. Mamas to say why in this particular patient, we are not going to discuss surgery versus angioplasty, but in given patient, why angioplasty would be preferable over surgery. Over to Dr. Mamas.
So thank you for the invitations, and congratulations to Dr. Bout for a very nice overview of some of the literature. It's a real pleasure to present my interpretation of the case, and in front of such an eminent panel of Indian physicians and surgeons, and to see my good friend, Dr. Kamal Sharma. So let me just load up my, why is it, let me open, oh, sorry, it's not letting me, oops, let me just, sorry, it's, oh dear, it's just gonna, yep, okay. I'm gonna have to quit and reopen. I'm going to rejoin the meeting. For some reason, it's not letting me do it. Let me just, 2 seconds, I'm going to rejoin.
Meanwhile, chairpersons, any comments on what Dr. Priyank Bhatt presented? My comments is that it's why is the world so unequally equal? Why the rules differ from one person to other person? Why is acute MI defined differently for surgeons and so differently for cardiologists? Why is an MI post-procedural defined as 3 times elevation, but for CABG it is defined 10 times elevation? Why, if the infarction reflects the injury, it is not proportionate to the time that you spend, whether on pump, off pump, or putting a stent, and if it causes an injury, be quantifiable equally? So I'm just leaving some important questions. I'm not answering anything by the time we have Dr. Mamas coming and talking his aspect, and then we can take this. And then we have the data of Excel, where the surgeons tend to differ, and even pre-combat, and they say, no, we are not going to accept this because you have tweaked the definition of acute MI, and your MACE is driven by MIs, which we don't believe, because MIs are something that elevations are bound to be more in our hand. So yes, Dr. Mamas, you're back here. So I was just trying to discuss why the world is so unequally equal or equally unequal, why troponins are defined differently for surgeons and cardiologists. So we can have your presentation. I was just doing the time filler, brain thinking, analyzing kind of a thing. Please go ahead.
So my discussion now will be why PCI is the best treatment modality in this patient for now. This is the clinical scenario. We've discussed it, a young patient with critical left main stem disease. But the debate is not about whether CABG or PCI is better in this patient. He's young, he will need both. We know that coronary artery disease is a progressive disorder. He will need both CABG and PCI at some point in the next 30 years of his life. The debate should be about whether it is better for the patient to have CABG now or in the future. And that's the important question. In this debate, I'm going to ask 4 questions, which I think are very important. Number 1, what do the trial data show us? And are the trial data applicable to this patient, a 37-year-old Indian patient? Number 2, does either option provide definitive treatment for the patient? Number 3, what are the patient-relevant outcomes for a 37-year-old patient that are important? And number 4, where and by whom should this patient be treated? So what do the randomized controlled trial data show us? We've seen this. This is the Excel data at 5 years, no difference in the primary outcome, although there was a slight increase in the risk of death. In terms of absolute difference, it was 3%, no difference in myocardial infarction, a big difference in revascularization. This is one trial. When we look at the characteristics of the trial, though, the average age was 66, 30 years older than this patient. 91% of patients in this trial were white. This patient is Indian. And only 3% of procedures were undertaken outside of Europe and the US. The Excel trial is not representative of the healthcare system or the patients that we are dealing here today with. When we look at the sum total of the literature, an individual patient meta-analysis, there was no difference in 5-year risk between CABG and PCI in left main, and no difference in 10-year risk in mortality, okay? The only difference is in revascularization. So in terms of the 2 options in such a patient, no difference in mortality. In terms of, are there studies to look at this patient group? No, there aren't. There are no studies looking at PCI versus CABG with 20 to 30 year follow-up data in young Indian patients, which is what this guy is. So does either option provide definitive treatment for this patient? Well, this is data from an individual patient analysis from the pre-combat trial, the trial with the longest follow-up data that's randomized. And you can see that in this trial, we have significant rates of reintervention in both arms. So this is not going to be definitive in either PCI or CABG. The patient will require further intervention down the line. This is 30-year follow-up following bypass operations. And you can see that after 10 years, both in PCI and CABG, you have an incidence of about 5% yearly for revascularization. This patient will need further procedures down the line. If we do CABG on this patient, who's very young, we will accelerate atherosclerosis in his native coronary vessels. This is data from this week's JACC imaging using sodium fluoride PET, showing increased activity in vessels that were bypassed. And you can see there's marked progression of disease in bypassed vessels. Look at the calcium score in the bypassed vessel, increases markedly at 12 months. In those vessels where it wasn't bypassed, no change. CABG progresses disease in vessels. Why is this relevant? Well, this is an analysis that we worked with Dr. Kamal Sharma of 500,000 patients with prior CABG in the United States. And we looked at, if they need revascularization, what is the modality? And you can see that in 90% of cases, the most common modality for revascularization in patients with prior CABG is PCI. Only in 10% of cases do these patients get a redo CABG. Why? If you look at the outcomes of redo CABG, they are much worse than PCI. So if you do a CABG on a patient and they need further intervention in 10, 20 years' time, then you're restricted to PCI because your risk from a bypass operation is significantly higher. And so given that this patient will need further interventions in the future, it's better to save his CABG, not for his left main stem currently, where there is no difference in mortality at 10 years, when you look at the sum total of data, but when his disease progresses and he develops multi-vessel disease, that's where the benefit of CABG lies. And so do PCI now. When he needs further intervention and his coronary disease has progressed, do CABG. That's where he has a mortality benefit, not now. And what are other relevant patient outcomes for a 37-year-old? Well, first and foremost, 37-year-olds, he has a family, he has to work. This is our data from UK looking at same-day discharge following left main PCI. It's safe. In my unit, he'll come in, he'll have a PCI, he'll go home on the same day. He can carry on with his life. That's not the case for surgery. This is data from the Excel trial showing patient-reported outcome measures and quality of life. You can see physical activity. It takes the patient 12 months if they have a bypass operation to get similar quality of life with regards to physical activity as it does for a patient that has PCI. He's back to normal within a day for PCI. For surgery, it takes 12 months. Look at quality of life measures. Again, takes 12 months for the patient that has surgery to reach the quality of life that a patient has PCI. In a young patient, their quality of life is impacted up to a year with surgery. Better to have PCI. And where and by whom should this patient be treated? Well, I would argue that they should probably have PCI, but in a unit that does intravascular imaging. This is data from my group showing a significant mortality benefit associated with intravascular imaging with left vein stem PCI. So if this patient presents in a unit where you can't do intravascular imaging, you should probably go for surgery. The second thing is it needs to be done by an operator with a high volume of left main PCI activity every year. There is very much a volume outcome relationship between PCI activity and outcomes. This is again data from my group looking at every PCI undertaken in the United Kingdom for left main, and it shows a clear volume outcome relationship. So any operator doing these sorts of cases should be doing at a minimum 16 left mains a year. If your centre can't offer that, send the patient for CABG. So I think in summary, in this 37-year-old patient who probably has 20 to 30 years of life expectancy ahead of him, neither CABG nor PCI will be the definitive treatment in this patient. He will undoubtedly require further revascularization as his disease progresses and grafts fail and stents fail. In left main stem PCI versus CABG, there is no difference in mortality up to 10 years from randomized controlled trial data. And certainly there's better quality of life data for PCI in such a young patient. He can get to work the following day if he has a PCI. For surgery, it will be months, and before he gets quality of life similar to surgery, it will be a year. I would say save his CABG for later, because this guy's coronary artery disease will progress. And we know that coronary artery bypass grafting has a mortality benefit in patients with multi-vessel disease, not in isolated left main. So do the revascularization in 10, 20 years when he requires it and he has more extensive coronary disease. If you do it now, you will restrict the ability, as shown in our US analysis, to do further surgery down the line. If you are going to do PCI though, do it in a centre that uses intravascular imaging and has a good experience and high volume operators doing left main PCI. So I thank you for inviting me, and I apologise for my technical problems at the start. Over to the discussion.
So it was a wonderful talk, Dr. Mamas, and I think you focus on this particular patient. The aim was to give your views on this particular patient. So Dr. Priyank, would you like to change your views after hearing Dr. Mamas, or you still stick to surgery as a first choice?
Fair enough. Am I audible?
Yes, yes, you're audible.
So I'll just make, I'll say that no, I would still prefer CABG because I believe that, as he said, that he has a long life ahead. But we are probably in this particular case, we are going to do a minimal invasive surgery. We are going to send him out of our hospital on 3rd or 4th day. So sending him on next day or 3rd or 4th day, I don't think financially or any other way, family-wise, it's going to make a huge difference, especially in this part of the world. Also, I think Lima to LAD is like our holy grail. We hold on to it. We revere it so much that we have so much faith in Lima to LAD anastomosis that we, all of us, believe that a good Lima to LAD will last a patient a lifetime if it is done nicely, good Lima to LAD. I was not aware of the article that he just mentioned. Probably it is just published recently that CABG enhances or increases the chance of the coronary artery disease in the native vessels. I'm actually not aware. I apologize for that, but notwithstanding, I would still want to do a Lima LAD for this patient.
See, is mica surgery gives as good quality of distal anastomosis as open heart surgery?
If it is not, then one should not do it.
I agree. That's why it was the question. And I asked question to Dr. Mamas. You said that bypass surgery increases coronary disease that we've seen in many patients, but is it proximal to the graft or only proximal to the graft or distal as well? See, whenever you put graft or Lima, it's definitely proximal disease progresses. But is it true even for distal vessel?
Yes. So if you look at this slide that I showed in this picture from JACC imaging this week, it's throughout the vessel. It changes the flow dynamics. So we do see both in observational data and this data as well, which I think is an important consideration. So I think this case really shows the beauty of personalizing your approach. If this was a more elderly patient, I would say CABG. In such a young patient, I would say start with PCI. He'll need further revascularization down the line. Then you do CABG where the mortality benefit is.
And is disease progression same with SVG graft as well as Lima graft, or it's more with SVG graft and less with Lima graft, which has very nice flow?
So in this series, they didn't specify whether they're vein grafts or arterial grafts, but certainly there's a lot of other observational data that has reported both in arterial grafts and vein grafts.
If I have time for one last comment, that's exactly what I also would say, that traditionally we have been taught that, Lima releases nitric oxide and various substances which kind of makes it last longer than a radial artery or a saphenous vein. So this is quite interesting, and we must look into it if there are any technical changes that we can make. Bilateral memories and other success stories are because of the Lima, which flows through all these and keeps the distal arteries and itself patent, and the longevity of it. So
I think if you get a patient, as my friend Mamas was saying, if you get a patient with 37 who's got a left main 110, you're probably dealing with either a FHF, familial hyperdyslipidemia, or you have a lipolytyl A in our part of the world, which is so common that almost 20 to 35% of the patient will have a lipoprotein small a mutations that they carry. And it's very likely that whatever you do, this guy's probably going to come back, maybe in 5 years, maybe in 10 years, maybe in 15 years, when you need to do the alternative therapeutic procedure, which may be required. So I think we need to also be talking about disease modification and medication, but also counseling and learned consent, that we need to discuss this, that probably this is not the last procedure. But telling him that the Lima will last your lifetime is probably going to be false, because he may come with the right coronary disease. And his patient is not going to comprehend that his Lima is flowing or not, because we've had a lot of times done patients with acute MI where the grafts were done to the whole of the left system, and he presents with inferior wall MI. Surgeon would have a time to explain it that it's not my graft, it's something else that has got occluded. Chair, any other comments from anybody from Chair? Yes.
With the right coronary, he will reach you.
Kamal bhai, I think if there is a left main disease, he will also need a graft to OM. Exactly. So, you may have a longevity for Lima to LAD, but your graft to OM is not going to last for his lifetime for sure. Unless you put a Lima Y or something like that, or a Lima to radial Y graft to OM. So that is going to be another, and as sir said, this is likely to be, and he is likely to have an highly atherogenic milieu. So chances of him coming back for something else, or one of distal disease is extremely going to be extremely high in this patient. So I think, in my humble opinion, it should be PCI now, and maybe subsequently wait for him to be reaching to Dr. Priyank at a later stage.
The thing is that you've got to also consider the individual expertise of each unit. As I tried to say, that the Excel trial and all these trials are in European population, North American population. We know that Indian patients are very much higher risk, present younger, much smaller coronary vessels. We shouldn't be doing left main PCI in centers that aren't used to doing this. It should be a high volume experience center. And similarly with, off pump, I'm sure that your center has excellent results and you do high volume, but there are many centers in the US, particularly where they have very low volume surgical experience. And, the patient shouldn't be having surgery in those sorts of centers. So you've always got to consider, where the patient is at and the experience of the surgeons and center as well.
So, Kamal, should we conclude or?
I think, yeah, we can conclude. Dr. Mamas, your closing comments on definition of myocardial infarction post CABG, post PCI, 3 times and 10 times of the biomarkers. Do you agree or do you disagree? Because that's what we were discussing when you logged out for a couple of minutes.
Yeah, well, I think that the problem with this is that we've got now assays that are very sensitive. And so we've just published a paper in the European Journal of Cardiothoracic Surgery of patients undergoing CABG. And if you measure high sensitivity troponins in these patients, over 90% of them will have periprocedural MIs. That's ridiculous. You can't have that suddenly 90% of patients undergoing cardiac surgery have periprocedural MIs. So I personally think that we shouldn't be thinking about periprocedural MIs, whether it be in PCI trials or surgical trials, because in the era of high sensitivity troponins, many of the trials have suggested that actually it has no prognostic impact, a small rise in this very sensitive biomarker. So I wouldn't use this in these sorts of trials.
Kamal, when I was doing, Kamal, can you hear me?
Yes,
Kamal? You see, basically, when I was doing duty in Jaslok Hospital, we had one of the top cardiac surgeon of the country. And in post-operative round, I saw ST changes, means it's like non-Q anteroseptal MI and phoned him at midnight. And he was so angry that from that day onward, I was out of his rounds. But because surgeons, they don't consider ST changes or non-Q MI as a MI. So their definition, as Kamal says, are very different than what we do. If after angioplasty you see ST changes, you are scared, but surgeons are not scared. So I think their thinking is very different.
Sir, I think 80% of time the graft closures are hidden under the sternal pain.
Yes.
That is why.
For the patient so scared.
But even the data show that on table or before discharge, there are around, I think, 3 to 5% graft which would close. I don't know. I mean, how many times we have diagnosed them, because half the time even the ECGs are not done on daily basis, and even some small changes and troponins, if they are elevated, because first we don't do it, and if it is done, usually that will be passed on as you have just fondled with the heart. So there is some rise in troponin which is likely to be there. So that's how things will go.
I have one question to Dr. Mamas. How frequently you have encountered that? You mentioned that after putting a graft in the LAD, there was a progression of the disease distal to the graft. So how frequently you encountered in your clinical practice? And what is the probable reason for that?
The problem is that we don't routinely do cardiac catheterization in these sorts of patients. So, we don't know. And we know from data that, for example, many vein graft occlusions are asymptomatic in patients. And so unless you do a systematic assessment, as was the case in the JACC imaging paper that I briefly showed during my presentation, there's no way of knowing how frequent something is. So the short answer is, in my practice, I don't know, because I don't routinely cath these patients unless there's an indication.
Thank you.
So, Kamal, should we conclude now? Okay.
Yes.
Yeah, thank you very much. Thank you, chairpersons. Thank you, moderators. Thank you, my friend Mamas. Thank you, my friend Priyank. Good to have you both. That was a wonderful debate and a very learning experience. Always a pleasure to have you all. Thank you. Bye-bye.